In this tutorial, we'll review sudden cardiac death associated with mitral valve prolapse and mitral annular disjunction. We'll start by reviewing two cases of women who were found to have bileaflet mitral valve prolapse and associated mitral annular disjunction, one who was referred to her cardiologist simply due to palpitations, and the other who presented after an out-of-hospital cardiac arrest. We'll then try to identify signals in these cases that may be predictive of malignant arrhythmias and review what can be done to mitigate that risk. The first case is that of a 53-year-old woman who was referred to a cardiologist due to palpitations. While reviewing her past medical history, her cardiologist learns that she has had prior episodes of syncope with prodrome. A transthoracic echocardiogram was ordered, which revealed bileaflet mitral valve prolapse and mild mitral regurgitation. A 30-day Holter revealed a PVC burden of 7% with 2 short runs of NSVT. A cardiac MRI was subsequently ordered, which revealed focal basolateral late gadolinium enhancement as well as mitral annular disjunction. The second case is that of a 36-year-old woman who presented to the hospital as a witnessed out-of-hospital cardiac arrest while eating dinner at a restaurant with her husband. The initial rhythm reported by EMS was ventricular fibrillation, for which she received 5 shocks before achieving ROSC. ECG on arrival to the hospital revealed normal sinus rhythm with a normal QTC. Left heart catheterization revealed clean coronaries, and transthoracic echocardiogram revealed bileaflet mitral valve prolapse and trace mitral regurgitation. A subsequent cardiac MRI revealed focal basolateral late gadolinium enhancement and mitral annular disjunction. Prior to discharge, the patient received a subcutaneous ICD for secondary prevention. But the challenge becomes trying to determine the likelihood that our first patient develops a life-threatening ventricular arrhythmia like our second patient, and then trying to develop a thoughtful approach for risk mitigation. Let's take a look at some of the proposed algorithms for mitigating these risks. Several algorithms have been proposed in recent years, including this one from a 2022 consensus statement on arrhythmic mitral valve prolapse from the European Heart Rhythm Association, and this 2023 update from a review paper by Dr. Serrano at the Mayo Clinic, as well as this 2024 update in JACC. All algorithms start with the clinical history and agree that if a patient survives sudden cardiac death, they should get an ICD. They also all agree that whether a patient with mitral valve prolapse is asymptomatic, minimally symptomatic, with symptoms of palpitations, pre-syncope, or syncope, or a survivor of sudden death, they should all undergo additional cardiac imaging for further risk stratification. And as we saw earlier, the most helpful studies are echocardiography with strain and cardiac MRI. They also all agree that all asymptomatic and symptomatic patients should undergo Holter monitoring, and that the number and severity of high-risk features acquired by cardiac imaging should guide the frequency of Holter monitoring follow-up. For those with only a few high-risk features, less frequent Holter monitoring may be warranted, but for those with several high-risk features, a Holter every 6 months to a year or implanting an ILR may be reasonable. And finally, for those who are found to have complex PVCs, or ventricular arrhythmias, they propose consideration of prophylactic ICD, or surgical repair if there's an indication based on the severity of mitral regurgitation, and that if there are frequent appropriate ICD therapies for malignant arrhythmias, to consider VT ablation and initiation of antiarrhythmics. While prophylactic ICD implantation has not been endorsed in any formal guidelines, it is being trialed at institutions with dedicated mitral valve centers. Dr. Mark Miller at Mount Sinai describes the case of a 55-year-old woman who was referred to their center due to palpitations, who had imaging findings of bileaflet mitral valve prolapse, MAD, and focal late gadolinium enhancement. Due to the finding of complex, short-coupled, and pleomorphic PVCs with NSVT on Holter monitoring, decision was made to implant an ICD. And 1 month after ICD implantation, the patient received an appropriate shock for ventricular fibrillation, which had been initiated by PVCs. Despite introduction of beta blockers and flecainide, the patient continued to receive appropriate ICD shocks for VT and VF, so decision was made for the patient to undergo papillary muscle VT ablation. Here we can see that this was a patient who presented with palpitations, was found with high-risk PVCs and NSVT on Holter monitoring, for which a prophylactic ICD was implanted. But zooming in on this algorithm, we can see that one of the considerations is mitral valve repair. So let's briefly review some of the data looking at mitral valve surgery to reduce ventricular arrhythmia. Unfortunately, there is limited prospective data, which currently suggests little improvement in PVC burden. In this study of 32 patients from the Mayo Clinic who were referred for mitral valve surgery due to mitral regurgitation secondary to bileaflet mitral valve prolapse, no significant change in PVC burden among the cohort was identified post-op. Interestingly, anecdotal data emerging from Mount Sinai, where they are integrating open-heart cryoablation with mitral valve repair, seems to suggest that this might be a viable strategy for a subgroup of patients. Here they report the case of a 35-year-old woman referred to their clinic due to palpitations who was found to have bileaflet mitral valve prolapse associated with moderate mitral regurgitation, mitral annular disjunction, and characteristic late gadolinium enhancement. Although her PVC burden was just 4%, she had short-coupled pleomorphic PVCs as well as multiple runs of NSVT. She was initially offered an ablation for the papillary muscle VT, but after multiple recurrences, after 2 radiofrequency and cryoablations, she was referred for mitral valve repair. And 1.5 years post-op, her ILR reportedly reveals no evidence of PVCs or NSVT. Returning to our cases, we can now attempt to tally up their respective risk signals. Both patients have bileaflet mitral valve prolapse with associated mitral annular disjunction and only traced to mild mitral regurgitation. As we previously discussed, bileaflet prolapse is 6 times more common in patients who develop significant arrhythmias, and mitral annular disjunction is at least twice as prevalent. And notably, although the severity of mitral regurgitation is not impressive, we know that the majority of patients who go on to develop sudden cardiac death from mitral valve prolapse only have trivial to mild mitral regurgitation, like our patients. Here are representative cines from each of our patients. Here you can see the extent of the mitral annular disjunction during systole. And here is a frame from the lateral annulus tissue Doppler from our 53-year-old patient with palpitations. As you can see, it is just approaching the threshold of 16 centimeters per second, characteristic of the Pickelhaub sign, which we know is 3 times more common in patients who develop malignant arrhythmias. Each of our patients had characteristic late gadolinium enhancement along the basolateral wall, which we saw was 5 times as common in patients who developed malignant arrhythmias. Next, we can take a look at their respective baseline ECGs, which you'll note have T-wave inversions in the inferior leads, which, interestingly, was found in 83% of patients who had malignant arrhythmias. Holter data from our 53-year-old patient reveals short-coupled PVCs, and our 36-year-old patient has PVCs as well. And in both patients, the ectopy is pleomorphic with multiple morphologies, which we saw may confer a 2.5-fold increased risk of mortality. And finally, we know that both patients had prior histories of syncope and presyncope, which is found in 95% and 60% of patients who went on to develop malignant arrhythmias, respectively. And while current guidelines do not advocate for prophylactic ICDs, we saw that to mitigate the risk that our first patient succumbed to a malignant arrhythmia, she should continue to be monitored with at least yearly Holter monitoring, and possibly start a conversation about the risks and benefits of prophylactic ICDs.